Hey everybody, it is 3 o'clock here in the Midwest Central Time, and today I wanted to finally talk to you guys about pharmacodynamics and pharmacokinetics, because I know I've been getting a lot of messages about just the gravity of all the pharmacology information you have to know for anesthesia, because obviously your life is drugs and it's a lot. And I know, you're looking at all these different sources in the textbook, and then you have your PowerPoints, and then you have the teacher, and you have all these things. So I wanted to kind of give you guys that big picture viewpoint that I like to give you guys, give you some examples, break some stuff down, and hopefully make this all make sense, because I know it's a lot. So I know this was last minute, so I will get the replay up for a little bit, and then I have something exciting that I have, I'm in the process of making that I think will help you guys understand the drugs even more. So, hello Tequila, how are you? So when you guys pop in, go ahead, and I'd love to just hear if you are a nurse, if you are an SRNA, kind of where you're at in the journey. And I like to be brief, quick, to the point. This information is not exciting, but it's super important. And I really just want to lay the foundation today of how the dynamic portion and how the kinetic portion work. Because I think if you guys have a strong foundation, all the other stuff with the drugs is going to make sense. All right, so let's go ahead and dive right into this stuff. Now, I did put the PDF, those of you who get my emails, I sent you guys the PDF on the email that you have, and I also put it in my announcement for this live in the comment section. So you guys are able to just download that PDF off of Google Drive, and I will reference it while we are doing throughout the class. Hi, Megan. Hi, guys. Good to see you. You guys can see me. It's like super bright here. Okay. All right. You guys can hear me okay? You guys are good? All right. So pharmacology in general is when you're giving anesthesia and when you're a nurse and you're giving drugs, I want you guys to kind of think of yourself as like a chemist, right? Like sometimes we make the joke like we're a bartender, but I want you guys to think of you guys like a chemist. So you are giving drugs and you are creating reactions in your patient's body to help reach certain goals. And with anesthesia, those goals are making your patients amnestic, pain relief, analgesia, and immobility, those type of things. So you have to understand the dynamic portion of the drugs and most importantly, the kinetic. I'm going to go through the dynamic stuff really fast because the kinetic stuff is actually more important to what we're doing as anesthesia providers. And I do want to tell you guys that in general, as you are learning all the anesthesia drugs, if you're studying for your interviews, whatever it may be, it's a lot. And I know it's overwhelming, but I will promise you guys at some point, this will all click and you will be in practice and you'll be like, oh my God, this like finally all freaking makes sense. So I will promise you at some point, this will all make perfect sense. And I'm hoping after today, some things will click in your brain and you guys will have a solid foundation and will go along your merry way. So if you have your PDF, the first page, I give you guys all the definitions. On the left side is all the dynamic, pharmacodynamic information. On the right is all the kinetic. So let's just go through the dynamic stuff super fast, and then we'll focus more on the kinetic piece. So when you're looking at the pharmacology pieces, the pharmacodynamics is what the drug is going to be doing to the patient, right? So it's the clinical effect of the drug. We give an opioid, we want them to have pain relief, right? It's that clinical effect. And one way you can look at that is that dose response curve. So I guys got a little handy whiteboard. I went to Walmart. I was so excited. So the dose response curve, super simple. S-shaped sigmoid curve. On the x-axis, you have your potency, which is how much drug or what's the dose required to get a clinical effect, right? And then on the y-axis, you have your efficacy, and that is looking at what is the ability of the drug to actually produce or give you a clinical response or the max effect of the drug, okay? And this is talking about like the ED50, the ED90. You might see that in your studies, and that's saying what is the effective dose for 50% of the population, or what is the effective dose for 90% of the population. So that all has to do with the dose curve. If you have a shift of the left, the drug is more potent and you need a lower dose. If this curve is shifted to the right, it's a lower potency drug, the less you need. Now, when we give volatile anesthetics, neuromuscular blockers, those actually those actually have a pretty high potency. So you need less drug to kind of give that effect. Okay, so that's it. That's all dose response curve is. And then I will also, one more point here. When you reach the plateau of here, that means once you've reached that plateau of that drug, giving more is not going to give you any more of a response. So when your patient is paralyzed, they're paralyzed. Giving more rock when they have zero twitches is not going to do anything. Okay, so that's dose response curve. Other thing is LD50. That's the lethal dose of the drug. That has to do with your therapeutic index, which is a measure of the drug safety. And pretty much in anesthesia, you're kind of that bridge between life and death, right? And that's kind of what the therapeutic index is. What is the dose that's going to give me the desired effect, but not kill the patient? And that's essentially what your job is. So that's all that is. Volatile anesthetics, the gases that we give patients, have a very narrow therapeutic index. You give too much, you could have depression of their cardiac. You can go into cardiac arrest, stuff like that. That's why anesthesia has high risk. That's why you're there. That's why you're going to know these drugs inside and out. But that's basically what the therapeutic index is. Let's see, going back down on your side here, we've got stereochemistry. I don't know if that gives anybody PTSD from chemistry, but that's talking all about the 3D structure of the drugs, chirality, and I can't even say this, enantiomerism. It's like the mirror image, organic chem, biochem stuff. Not going to go into that today, but those are those racemic mixtures of drugs. So ketamine, cisatracurium, morphine, toradol, those are all actually racemic mixtures. I know Patrick's like me. I know. I was like, I saw that. I'll throw it up there, but that's part of the dynamic piece. And then super important, I really want you guys to take away from the dynamic portion of this is agonist and antagonist, all right? So agonist drugs, we know, stimulate the function of a receptor, or you can think of they turn that receptor on. So propofol, GABA agonist, turns GABA on. Epinephrine, dopamine, alpha-1, beta-1, dopamine receptors, it turns them on, okay? So that's what agonist is doing. And then you have your antagonist, which is like rocuronium, the paralytic. They're not really making a receptor work, but they're blocking what the receptor wants to do. So rock is sitting in the neuromuscular I can't even think of the word, the neuromuscular junction. It is sitting on those receptors. It is not letting acetylcholine bind, so the patient cannot move. So it's not changing the receptor, it's just blocking it. Metoprolol, beta blockers, right? Just blocking the receptor. So that's the difference. So that's the difference between agonist and antagonist. And another quick point I want to make before we get into the kinetic and all the good juicy stuff is synergism. So a lot of what you do in anesthesia is synergy of drugs. So take, for instance, you give Versed and you give fentanyl, right? It's kind of that concept of the drugs are going to synergize together. So it's kind of that you can be like a one-hit wonder. You can just give some propofol. You can give a little bit of everything and then decrease those dosages. So if I give Versed and I give fentanyl, I'm not going to have to give as much propofol, right? Because those drugs are going to synergize. If I give a paralytic and then I turn on my volatile anesthetic, the volatiles actually also help relax the muscle of the patient. So it's going to synergize and that patient's going to be pretty darn relaxed for surgery. Now, potentiation, I don't want you guys to get those two confused. Now, potentiation is, say your patient is getting narcotics on the floor, right? So say, this actually just happened to me. So say your patient got like a milligram of Dilaudid right before they came to you for surgery. Now you're going to give them propofol. So what's going to happen? You could potentiate the apneic effect of the fentanyl with the propofol, and now you potentiated the drug, something like that. Does that make sense? So I don't want you guys to get synergism and potentiation. Another thing, so if the patient got, once again, maybe got some fentanyl or got something on the floor and then you give them propofol, they might be hypotensive. They could potentiate the effects of one another, okay? So those are the difference between the two. Hi guys, how are you guys doing? All right, so that's dynamic piece. Do you guys have any questions on dynamics? I wanted just to kind of go through those fast, and I want you guys to have that list and that PDF so that in your brain, you know the difference between pharmacodynamic portion pieces of it and pharmacokinetic pieces of it. Yes, absolutely. Additive effect is 1 + 1 is 2. Synergism is 1 + 1 = 3. So a little bit of Versed, a little bit of fentanyl. It's going to be not 2, it's going to be 3 because we're going to have synergism. We're going to get more of the effects we want. The patient's going to be more relaxed. Very good. Potentiation is 1 + 0 = 3 because you're potentiating the effect. You're taking a drug and it's going to potentiate the effect of another drug. Makes sense? And that is in the PDF for you guys as well. Any other questions on dynamic before we move into the kinetic portion? And I wish this stuff was more exciting. I was trying to think of a way to make this super exciting, but it's just, it's just drug info. I got the other fun stuff. I got something else for you guys. No questions about that right now? Okay. So kinetics, so now we're gonna flip the script, right? Is dynamics is, we just talked about the clinical effect of the drug. So what the drug is going to do to your patient's body. Now kinetics is what the patient's body is going to do to the drug. And I want you guys to start learning, for those of you that are new to anesthesia, and just to remind you guys that are not new to anesthesia, there's not really like rules and protocols in anesthesia. And I think that's the hardest thing is you want to hold fast to these, okay, just tell me this and I want it to be true and I want to make it work. And it's not the case. There's so many variables. When you are giving a drug to a patient, you don't know, number one, how that patient is going to respond, right? Because they could have liver problems, kidney problems. They could be obese. They could be 100 years old. There's so many. They could be dehydrated. They could be on this medication. There's so many different things that change the kinetics of a drug. So we're going to go through like the big umbrella picture so you guys can understand, but always keep in mind there's always going to be variables. And I think that's one of the hardest part of learning anesthesia. Okay, so I'm going to say a lot, but it's not like true hard and fast stuff. Okay, and I will break some of this up and give you guys some examples as we go. All right, Ashley, say the numbers definitely help it click a little bit better. Awesome, fantastic. Okay. So now kinetics. So I know the books and I know the articles kind of go through this in a certain way, but for my brain to work, I've kind of flipped the script a little bit because I think this will help you guys understand it a little bit better. So let me get out my awesome whiteboard that I got. Can you guys see this? If not, let me try this one because I know there's like a little bit of a glare. Okay, so this is the big umbrella picture that I want you guys to think about when you're giving a drug, and it has to do with the compartment models. Now in anesthesia, there's the one compartment model and there's like the multi-compartment models, okay? So I want us to focus on the multi-compartment model because that's more so how anesthesia drugs work. So this is what I want you to be thinking when you can you guys see this, okay? So you have your syringe of medication and you inject it into your patient's vein and it goes into plasma, right? And remember, this is a dynamic process. So once it hits the plasma, a lot of things are going on. Some of the drug is going to go to the site of action, right? It's going to go where it's supposed to work. Then some of the drug is going to go to the vessel-rich organ. So it's going to go to the heart, it's going to go to the brain, where all that blood flow is going, right? Some of the drug is also going to go out to the periphery. The periphery actually serves as a drug depot, okay? So muscle, fat, bones, periphery. Some of the drug is going to go there. And then some of the drug is actually going to be cleared and eliminated. It's going to go to the kidney. It's going to go to the liver. And there's also ways that you can clear drugs in the plasma that we'll talk about in a second. But essentially, you guys, this is what is happening. You are injecting, we'll say propofol. I use propofol a lot. We're injecting propofol, vein to brain, right? Propofol works at the GABA receptor. Some of it's going to go up to the brain, right? At that same point, some of it's going to liver and kidney to be cleared. Some of it's going to go out to the periphery and sit in the fat, sit in the muscle. Some of it's going to go here. So this is the big picture process. This is administration and distribution, right? This is what is going on when you give a drug. It is dynamic. It is not static, okay? Is that making sense? And I think I put in your PDF, I kind of wrote this like 1 through 4 kind of out for you guys, but I'm like a total like picture person, okay? And then on the flip side, so then I kind of use like a COVID example. So you've got the drug, you've got it going in all these different places, right? It's distributing to periphery, to the brain, to the liver, to the kidney. It's going all over the place, right? The drug is distributing around. You need to have a certain amount in your plasma, the plasma concentration for the drug to work, right? And remember, the drug is constantly moving all over the place. So eventually, right, so this is going to be the second half of this. So we've injected the drug in the body. It's been in there for a while. So now what's eventually going to happen? So now we're not going to have a lot in the plasma, right, because it's distributing, it's going around. So now my plasma concentration of the drug is low. So what's going to happen is now the drug is going to start dumping back from other places. So propofol was in the brain at the receptor. It's going to leave the site of action, go back to the plasma. Then it's going to be coming out from the periphery and dumping back into the plasma. It's going to be coming from the heart, come back to the plasma. And then it's going to be eventually cleared via the liver, kidney. Clearance, elimination, metabolism. We'll go into that a little bit more. Okay? So this is what's constantly happening. Drug is going in. It's going everywhere, right? Once it's kind of gone everywhere, now my plasma there's not a lot of drug there. So then it's going to start dumping back into plasma from all the places it's going, right? Some's going to be metabolized. Some's going to go here. This is what's happening around and around and around. Is that making sense? Like, is that kind of like that's the big picture of what's going on. If you can understand that, all this other stuff is going to make sense. Okay. Questions, guys? Can you guys see my little drawing that I did? Okay. I kind of think of it like, if you have a bunch of people, it's COVID, right? If you got a bunch of people congregating outside, we're all going to be running inside, right? Because there's enough outside. If there's too many people inside, then we're all going to run back outside. That's essentially what the drug is going to do. Okay? All right, good. I'm glad you guys can see my terrible little drawing here. Okay. So now that we've got that big picture compartment model, now let's kind of go through and break this stuff down and so you guys can actually utilize this in practice. So volume of distribution, I believe I put I got all the definitions up there just so you guys have those and you can use that to study with. Yes. Oh my God, Patrick. Beautiful. I'm actually going to get to that in 2 seconds. He was asking about plasma proteins, and we are actually going to talk about that in a second. So nice job. I love it. Look at you. So volume of distribution, right, is what we just talked about. Administer and distribute, right? That was that first part of that. And the volume of distribution is a theoretical principle, right? That's why I'm like, you guys, you can't really hold super, super tight to all this stuff. It's a theoretical principle, not necessarily a real volume, but it's a way we can help understand this stuff in our heads, okay? So now... actually, go down to your thing. I think I have a little, so below your little, I gave you a volume of distribution chart. So you're going to have drugs that are either going to be lipophilic, which love fat. Propofol is one of those. And you're going to have drugs that are water loving or hydrophilic, okay? And they like to be in the water. So this is key to understanding how drugs work, right? I did say we need a decent amount in the plasma for the drug to work, okay? The max effect of the drug is dependent to the plasma concentration. So we have to have enough in that plasma for it to work, right? And some of the things that are going to affect this volume of distribution is ionization, how big the drug molecule is, protein binding, which we'll talk about in a second, and then patient characteristics. If you're pregnant, you've got a lot of fluid, a lot of volume. If you're elderly, they actually have more fat, less water, stuff like that, okay? So lipophilic propofol is going to have a high volume of distribution, right? Because it is going everywhere. It's going into the fat. It's going into the total body water because fat loves fat, right? Like dissolves like, right? So it's going everywhere. So for propofol, you have to give 2 to 2.5 mg per kg. That's a pretty heavy dose, almost 200 of propofol for people to get them asleep because you need a higher dose to get in for the plasma concentration to be high enough, right? Because it is going to distribute everywhere, okay? Now, hydrophilic drugs, so water-loving drugs like the neuromuscular blockers, glycopyrrolate is actually a water-soluble drug. Now, they have a lower volume of distribution because they want to go in the water, right? They're going to want to be in the plasma. Propofol's going everywhere. High volume distribution all over the place. I need more. 2 to 2.5 mg per kg. Higher dosage, I need more of it. Neuromuscular blockers, rocuronium, don't need as much because it's actually going to be in the plasma, right? It likes to be in the water. I don't need as much. Okay? Is that making sense? Does that make sense to you guys? Yes, no, maybe so. And then I put in your chart, and you guys can't marry this because I gave you guys another chart below that. Now, I put lipid-soluble drugs, you would think, in theory, right, would be based on total body weight. Why? Because they have a high volume of distribution. They are going everywhere, right? So theoretically, it would make sense that they're totally based on total body weight. Not always the case. We're going to talk about that in a second. And then water-soluble drugs, we would think would be based on your more ideal and your lean body weight because we don't need as much because they're going to be in that plasma, right? So once again, do not marry that. I put it in there because theoretically it makes sense, but we're going to break that down a little bit more. So it begs the question, does size really matter? It kind of does. And when you guys learn about obesity and anesthesia, this is where, in anesthesia drugs, this is where this really comes into play. So I just want to give you guys kind of a brief overview of that. So total body weight is the patient's actual weight, right? And obviously we know for some of our obese patients, everyone has an ideal body weight of what they should be, okay? And so I did put a little chart there on how you dose the drugs. I know a lot of you guys get super confused with that, and it is. It's a confusing kind of thing. So I want to go through these drugs here. So like I said, lipid-soluble drugs, most lipid-soluble drugs are your anesthetics, right? Etomidate, propofol, your benzos, they work fast. Anything that works at lipid, it's going to go across lipid membranes quicker to the brain quicker. It's going to work faster. So in theory, those things are going to be based on your total body weight. Opioids are also lipid-soluble drugs, okay? Now the exception is remifentanil. So remifentanil, that's why I said you can't get married to anything here because there's always little caveats. Remifentanil is lipid soluble, but because it's metabolized by esterases, the way the drug actually works, you actually dose it on ideal body weight. Okay. So those are where those kind of pieces come in to where it's like you guys, I remember in anesthesia school, I just like someone just tell me in a way this makes sense, but it was always but this. So that's just what it is. However, is this kind of making sense though? So I gave you guys kind of a chart there. Versed, fentanyl, succinylcholine is actually based on total body weight. The maintenance dose of propofol is based on total body weight. The initial dose of propofol is based on ideal body weight, okay? So just get those in your brain. So you guys have that chart there, and then I would urge you to keep that and kind of keep adding to that so you can kind of like get this through your brain when you're in school. And I will say that, once again, there's all kinds of patient factors that can change this, but sometimes if you dose something based on total body weight, you could risk overdosing the patient, giving them too much. But on the flip side, if you give something an ideal body weight, you could risk underdosing the patients. Okay? So how are we doing, guys? Is that making sense? So I got your theoretically kind of what makes sense, but then there's the chart on how you actually should dose the medications. And we'll talk about context-sensitive half times too. That'll kind of clear that up a little bit. So opioid, lipid stuff, Versed, fentanyl, maintenance dose of propofol, all total body weight, right? And you kind of think about it in a way too is, succinylcholine is a very fast working depolarizing neuromuscular blocker. So you got to kind of give a lot of sucks up front to get all those receptors depolarized so the patient will be paralyzed. So once you kind of understand these big concepts, I don't want you guys to get stuck in this massive, I remember I used to lay in bed with a piece of paper just trying to memorize stuff and I wanted to die. I want you guys to understand, because if you can really understand how this works, you're not going to need to memorize as much because it's just going to make sense. All right, how we doing, guys? We good? I wish this stuff was more exciting. Okay, let's talk about protein binding really quick, and I'll make the big umbrella kind of heading of that. Okay, good. You guys are all right. All right, fantastic. So we have, obviously, plasma proteins in our body, right? The most abundant plasma protein that we have is albumin. We also have, there's another one, alpha-1 glycoprotein and beta-globulin, okay? So we have these plasma proteins. The take-home point here is proteins will bind up drugs, right? And if proteins bind up drugs, they're going to stay in circulation, right? Bound up. Now, the portions of the drug that are not bound up, that are called free drug, those drugs go out to circulation and to sites of action, okay? So protein-bound drugs sit in circulation. Free drug goes all over the place to work, okay? So clinically, what does this mean for you guys? I can't say that this is like the biggest deal ever, but however, if you get a very like cachectic patient or, a super sick, septic, older patient, right? And they have like low plasma, so low plasma protein, so low albumin. What means is there's not going to be as much proteins to bind up drug. So you're going to have more free drug out there, which means the drugs are going to be more potent. Make sense? So that's kind of where that comes. Low proteins, for whatever reason, patients have decreased liver function. Patients are elderly. Patients have maybe some kidney problem and they have increased protein excretion. Third trimester pregnancy, you're diluted out, so you don't have a lot of plasma proteins. Malnutrition, etc. So all of those patients you need to be thinking about, they could be very sensitive to drugs. That's why I always say start low, go slow. Okay, so that's kind of the take-home point of that. And then obviously that has to do, like Patrick had brought up earlier, with the volume of distribution thing, because it's going to affect the distribution of the drug. If more of the drug is bound up sitting in plasma, right, then there's not going to be as much going out to the site of action, affecting your volume of distribution. Okay? So that's kind of the take-home point there. Like I said, this really doesn't have crazy effect unless you really have a really sick patient whose albumin's like 1 or something like that, something crazy. All right. And then, yeah, like Patrick said, possible overdose for sure. So you want to be very careful with giving medications to them. And that's also when you're looking at the information on like a drug, you're looking at its protein binding. It'll be like 30% protein bound or 70% protein bound. And that will kind of give you an idea on kind of where to go with the drug based on that patient. Okay? All right, guys, we're getting through this. You guys are doing awesome. Good. So now let's talk about clearance and metabolism elimination, however you want to put it. So I gave you guys a chart. I actually made that chart when I was studying for boards. So some of these things I actually made when I was studying for boards. So they're all yours now, so you guys can pass boards. But like I said earlier, my schematic earlier, right? So even initially when we're administering and distributing drugs, some of that drug is going to be cleared, right? Even right when I get it, some of that drug is going to be cleared. And the rest of it's going to be cleared later on in time, right? So the drugs are constantly moving and going through stuff. So clearance can be defined as the volume of plasma cleared of drug per unit time. And that can be either via metabolism, kidney elimination, metabolism with esterases, etc. So let's look at some of the ways drugs are cleared from the plasma. So now we have given our drug, our propofol has went to the brain, our patient was sleeping, and now, we need our patient to wake up. We need some of that drug to start clearing. So liver obviously metabolizes drugs. We have our CYP450 enzymes, which I'll talk about more in a second. We have our kidney, which is kidney will especially take hydrophilic drugs, and those will just go right on through the kidney and be eliminated. We also have Hoffman elimination. So Hoffman elimination is a non-enzymatic degradation of drugs, and it's based on pH and the temp of the plasma, okay? And then as you can see in your chart there, Hoffman elimination is atracurium and cis-atracurium. Go through that. Oh, I'm so glad you asked that. Perfect. We will get to that in just a second. Lindsay said, what's the difference between plasma cholinesterase and non-specific plasma cholinesterase? Great question. So you'll see on your chart there, do you see, it says, so plasma cholinesterase is the same thing as pseudocholinesterase, type 2 cholinesterase, false cholinesterase, okay? That's all the same things. And those are responsible for the breakdown of succinylcholine, the ester local anesthetics, neostigmine, and mivacurium. And remember, guys, things can be metabolized in multiple ways. Some of them will go through plasma cholinesterase, some of them will go through liver metabolism. Then you have your ester hydrolysis, which you look in your chart. So ester hydrolysis happens via non-specific plasma esterases. Okay, so it's just one is broken down by plasma cholinesterase. One is broken down via ester hydrolysis, which means putting a water molecule on it, and it's metabolized via non-specific plasma esterases. Does that make sense? So they're two different things. The non-specific plasma esterases are broken down by ester hydrolysis by putting a water molecule on the drug, so it can be broken down. The pseudocholinesterase breaks the drug down right then and there, which is why succinylcholine works so fast, because we have these cholinesterases in the plasma that grab onto that sux and break it down immediately. The other one is via hydrolysis, putting a water molecule on it and getting rid of it. The nonspecific plasma esterases, esmolol, remifentanil, where remifentanil works so quickly, etomidate, and then cis-atracurium and atracurium. Does that make sense, Lindsay? That was a great question. So they're two different processes and go by two different drugs. Good. I'm glad. Awesome. And that's why I gave you guys that chart, because I remember I was like, dude, I don't even know. Because there's like, well, type 2 colon. And I'm like, what does all this stuff mean? It's all saying the same thing. False, pseudo, plasma. It's all cholinesterases. Okay. And then you can see that atra and cis-atracurium are broken down by both Hoffman and ester hydrolysis. Okay. So then you have that chart there. You can use that. And then I put, hepatic metabolism as well. And like I said, some drugs go through a variety of different metabolisms. All right. And so all right, you guys are good there. Oh, good. I make sure I talk more about Remy so you guys can understand that breakdown. Okay. Awesome. So now clearance, we're getting there, guys. Almost there. So clearance is super important to be thinking about when you guys are doing dosing intervals, right? So propofol drips, right? Putting your patients on a propofol drip, remifentanil drips, maybe giving ketamine dosing. We do ketamine for ARIS protocols, and I usually kind of dose them accordingly throughout the case, okay? So this is where we have to care about a steady state of a drug, okay? So once again, back to my schematic, right? So steady state. I think I put the, let me see, did I put the definition of steady state up in there? Yes. So steady state is when the rate of drug administration is equal to the rate that is being eliminated. Because remember, all these things are happening, right? Eliminated, going here, going there, going everywhere, right? So when we do an infusion rate, our infusion rate must equal the rate of drug clearance in order for the patient to continue staying asleep, right? So I have to give enough propofol to overcome what's being cleared in this dynamic process in order to keep my patient asleep, okay? In anesthesia, we kind of call that settling the patient, right? So initially I'm going to give that patient a bolus, vein to brain, 30 seconds with propofol. They're initially going to go to sleep, right? But then if I don't give more propofol, it's going to dump into the plasma. It's going to get cleared out, and eventually it's going to be gone. My patient's going to wake up. So what I want to do is I want to put them on a drip and keep them asleep. So I give them my initial bolus, go to sleep, right to the brain. It's moving around, but now I'm giving more, right? So now I'm getting this drip in. And the key here, and they love to talk about this on boards, is 5 half-lives have to elapse to achieve a steady state, okay? And you also need to be thinking about your depots, right? So patient's asleep, gave them a bolus of propofol. Now I'm going to turn my propofol drip to let's say 50 mics per kilo a minute. Let me just try 50 and let's see what's happening, right? Is that going to be enough to keep my patient asleep throughout the procedure, right? Because enough has to go in that's also being cleared. So that's essentially what you're doing when you're giving anesthesia. You're trying to settle that patient. Sometimes they make incision. I got to turn it up to 75 mics per kilo a minute of propofol, right? I got to figure out what it is for that patient, how much they need to stay asleep, okay? And then what happens is when you turn that infusion off, right? So now I want my patient to wake up. That's really where we care about this context-sensitive halftime, we'll talk about in a second, is when I turn it off, right? Remember, that drug's going everywhere. It's not only going to the brain and working, but it's been going out to the periphery, it's been to the fat, it's going to the muscle, it's going here. So now all that medication has to dump back into the plasma to be eliminated, okay? And we'll talk more about that in just a second. I gave you guys the definitions really quick on elimination half-life and elimination half-time. Elimination half-life is more so what we use in anesthesia. It's if you give in an IV bolus, you give a bolus of propofol, what is the time it takes for half that drug to be removed from the body? That's all that's saying. And then the elimination half times are looking at a fraction. That's more so kind of zero order kinetic stuff that we're not going to get into, because that's talking like aspirin, alcohol, phenytoin, that kind of stuff. I just want to focus on the anesthetic drugs. So just know that elimination half-life is what you care about, right? It's the time it takes for half that drug to be gone from the body. Okay, so I just threw those in there so you guys have those definitions, and then let's get back to context-sensitive half-time. So like I said, continuous infusion. I got to get enough propofol going to equal the elimination rate to keep my patient asleep, right? So now I want to wake my patient up, right? So now I care about context-sensitive half-time, because that is the time required for that plasma concentration to drop by 50% after I stop my infusion, okay? And that takes into consideration, how long have we been giving this drug, right? So once again, I'm going to turn my drug off, right? This propofol is going to come back from all over the place, and then it's going to have to eventually be cleared out via liver, and then for the patient to wake up, okay? And the longer we have the propofol infusion on, the longer we can fill up all those peripheral compartments. So the longer it's going to take to be eliminated. Same thing with fentanyl. Fentanyl is a lipophilic drug, right? So if we have on a fentanyl drip, if we turn it off, we got to give it time to dump back into the periphery to be eliminated. So that's all context-sensitive half-time is, okay? Time of that plasma concentration to decrease by 50% so my patient can wake up. Does that make sense? So you're kind of thinking about those tissue drug depots kind of both ways, right? So we've got drug going out to the tissues, accumulating out there, which is going to help our steady state, right? Because it's going to be dumping back into the plasma, going back to the brain, eliminated, whatever. But then eventually when we turn the drug off, it's going to be coming back from the periphery and eventually eliminated, and the patient wakes up. All right. So that's all context-sensitive half-time is predicting when those drug concentrations are going to fall so that my patient will wake up in a timely manner. That's it. Guys, good? And then the note about remifentanil, right? So remifentanil is a lipophilic drug. However, what did we say? It is metabolized by those nonspecific plasma esterases, right? So it is very quickly eliminated. So I could have remifentanil on for an hour, and the plasma esterases are going to eat it up, and the patient's going to wake up, right? Or the patient's going to, it synergizes with the propofol. Patient's going to wake up and be fine. All right. So remifentanil is the exception. Doesn't matter if I've had that on for 2 hours, I'm going to turn it off and that drug is going to be gone because the plasma is going to eat it up. However, my propofol is not going to be gone when I turn it off because it's moving and it's got to do all its movement. Guys, good? So that's what I said. There's no hard and fast rules. You still got to know the drugs a little bit, but at least you guys can kind of get this umbrella picture. So how are you guys doing? We're almost done. We're just going to go through drug metabolism here, and then I can take any questions. And we'll talk about a few kind of variables. You guys doing okay? I wish this stuff was like super exciting. Is it making sense? Is it clicking a little bit? Okay. All right, let's see here. I want to talk about the CYP enzymes a little bit. So in the same regards to, we're talking about clearance, elimination, metabolism, all the things. So metabolism is basically you're modifying a drug so that it can be broken down and eventually excreted, or making a drug inactive, right? And there's kind of phase 1, there's phase 2. You can put a sugar molecule on it, like conjugation, hydrolysis, put a water molecule on it so you can pee it out, go through the kidneys. So that's essentially what metabolism is doing. And it's kind of that drug biotransformation piece. So I want to talk about the CYP450 enzymes really quick, because that is super important with anesthesia. So you have these CYP450 enzymes. They are in your liver. They're also in the lungs. They're in the kidneys. They're in I believe your adrenals, your GI tract. They're kind of all over. And different sort of chemicals can influence how these enzymes are actually going to be expressed, okay? So if you have drugs that are inducers, right? So alcohol, smoking, barbiturates, like the old school anesthetic drugs, marijuana, dilantin, all of those things induce these enzymes, okay? So what happens is drugs like propofol, local anesthetics, your opioids, your Dilaudid, your fentanyls, and your benzodiazepines, those patients that are on barbiturates, that drink, that smoke, that marijuana, all the things, they're going to be chewing those drugs up, right? Like chewing them up. So for those patients, I'm going to want to have more of a synergistic effect, because if I just give propofol, they are going to chug through that propofol like nobody's business, because their CYP450 enzyme system is induced, right? Because of their lifestyle or because of the drugs they're on. So they're going to need more. Or I hit them with 4 of Versed. I give them 100 of fentanyl. I give them 20 of ketamine, 10 of ketamine, and then I hit them with just a little bit of propofol, and usually that'll knock them out, right? So those are some of the things you're going to think about with your patients that are, partiers or on barbiturates or something like that, okay? And then on the flip side, you have drugs or chemicals that can inhibit these CYP450 enzymes. So if that's the case, you don't need as much. So this isn't really quite a concept in anesthesia that I really focus on, is the inhibitors, but patients that are on maybe like Prilosec, SSRIs, stuff like that, they can actually inhibit these enzymes, and then you could have an increased drug plasma level of them. But like I said, not a huge deal. I don't know if you guys, maybe in practice, you guys see a lot with the inhibitors, but it's mostly the inducers that you have the problem with. Okay. And then patients that are on, be really careful, patients who are on seizure medications, they tend to chew through like rocuronium and stuff like that. I mean, it's like giving water. I mean, you give 50 and they've got like twitches and they're like moving on the table the next second. So, stuff like that. Okay. Makes sense. And then, like I kind of said earlier, another piece, we talked about clearance, we talked about metabolism, renal elimination. Like I said, hydrophilic drugs are very easily eliminated from the kidneys. Opioids, your propofol, stuff like that are lipophilic. We have to kind of change those to be hydrophilic to be able to go through the kidney and be eliminated. So that's just another one of those processes. Not going to go too in depth with that, because I think you guys understand that. That kind of makes sense. I'll just talk about a few variables here I want you guys to be thinking about, and then that's about it. So like I said, I wanted this to be a nice big fat umbrella, like big picture, because that's what I like to do. So you guys can understand this, use the charts that I gave you, fill them in, think of any questions you have, etc. But always remember, like I said earlier, your patients are going to come with many variables. That's going to change a lot of what you're doing, which is why we get paid what we get paid, which is why we have to be vigilant, which is why we have a job, right? Because our job is to know drugs and how potentially they're going to interact with our patients, their bodies, etc. So things like age, older people, elderly people, decreased proteins, decreased body water, increased adipose tissue, all right? So you have to be thinking about those. So if they have decreased water, if I'm giving water-soluble drugs, right, those could potentially be very potent in them, right? Lipid-soluble drugs, they have increased adipose tissue. If I give lipid-soluble drugs, they could actually last a little bit longer. And that's kind of why if you give propofol, you have to go kind of slow. They also have decreased cardiac output, right? So it's going to be a slower onset to get that drug to the brain, because we have less cardiac output and blood to take it there. So elderly people, right? We don't want to give them a lot of drug. We give them a little bit of propofol. It might take like 2 minutes for it to get to their brain and work, but it's also going to sit out in the fat a little bit longer. So we have to be very careful with dosing them. And then I talked about like albumin, patients with poor nutrition and their plasma protein status that can throw the volume of distribution off. Obese patients have completely different volume distributions, which is why it's crucial to kind of understand ideal versus total body weight. And I always say, err on the side of caution, always give less, because you can always give more. Hepatic disease, renal disease can change everything. I know if a patient has really, rocuronium is mostly metabolized in the liver. So if you have a patient with liver disease, be really careful with giving that rock, right? Because they could hold on to that and they could be paralyzed for quite a long time. So a lot of times you could use cis-atracurium for those patients who have really bad kidneys or really bad livers. And then patients with CHF. It's a blood flow problem, right? We have a perfusion problem. So we want to give less, because potentially our drugs could be pretty potent. They might take a while to get there. We might have to wait a couple minutes for them to fall asleep, but we don't want to give them too much, right? So those are all the things that you are constantly thinking about. And once you have this foundation that we went over to today, the dynamic, the kinetic portion, once you have that solid foundation, you can, all of this stuff will start to make sense, right? But you've got to understand this stuff to understand the rest, okay? So what I have is I'm almost done with it. I'm trying to get it done. But I have put together essentially an awesome PDF it's called your Anesthesia Drug Drawer Guide. And essentially what I've done is I've gone through IV anesthetics, opioids, non-opioids, what else? Neuromuscular blockers, pretty much all the drugs. When you pull out your drug drawer guide, pretty much all those drugs I've went through. I touched on local anesthetics. I didn't get into volatiles because that can be like a whole other beast. But I've given you I've created a PDF that's almost done of all those drugs, all the need to know information that will help you, etc. And then I have like a little video, quick video to kind of go along with it to fill in the holes. So I am almost done with it. If you want to pre-order that, I will put the link up for you guys to pre-order that. And then I will get it out to you next week. But essentially, it's going to be almost like another foundational piece of all the need to know drug information of all the anesthesia drugs that you are going to use over and over and over and over again. So I can help you guys kind of remember. I got tips and tricks to remembering some of the dosages and some of the things and all the need to know stuff. So that will be available. If you want to pre-order that today, you can. And then I will get that out to you guys next week. So questions about any of the stuff we went through. I know it was kind of a lot, kind of dry, but questions. I appreciate you guys hanging out with me. And I will get this replay up and then make sure you guys download your PDF. But any questions? I also did not talk about ionization. I was thinking of maybe talking about that a little bit next week because that's kind of another heavy topic. But if you have any questions about ionization, let me know. But I will try to cover that next week. So, guys, any questions on anything? Oh, hi, Rebecca. I'll get the replay up, so don't worry. Don't worry about it. Questions? Oh, thank you. All right, awesome. Thanks, Patrick. Thanks for your input. Look at you dropping knowledge, finishing your semester off strong. Lindsay, thank you so much. You're so welcome. I hope it helps. Like I said, use those charts. I try to give you guys all these charts that I've made myself when I was studying for boards. So kind of use those and fill those in and ask questions. I'm here if you guys have questions. Yeah, it's all about building the foundation. Once you guys build your foundation, it'll all click and go into place. And I'm really excited to get you guys my drug drawer guide. I think that'll be super helpful, and it's succinct. I try to keep every drug class to 1 or 2 pages of just kind of the need to know stuff of the drugs you're using over and over and over again. And I hope this lecture and whatever, this talk here that I did will kind of help it all kind of make sense. Because this is literally what I think about when I'm giving my patient propofol or drug. I'm okay, it's going here, it's doing this. This will just becomes second nature to you guys. I promise you, all this stuff will just click. All right, good. You guys are good. No questions about anything? We'll talk about ionization. Do you guys want to talk about ionization next week maybe? I can put a couple posts or stuff up about ionization. I didn't really go into that too much today. PKA, all that stuff. It kind of goes with local anesthesia. So that's a whole other, I touch on it a little bit in the PDF I'm making for you guys. So, all right. So if you guys don't have any questions, thank you guys so much for your time. I appreciate it. I know this was kind of last minute, but I'm so glad to have you guys here. Download the PDF. Oh my God, these dogs. Download the PDF. Like I said, it's there for you. And you guys can always message me if you have any questions or anything like that. So you're so welcome. I hope this was helpful. I hope a few things clicked for you because I know this stuff can be extremely overwhelming. All right, you guys, I will get this replay up and let me know if you guys need anything else in the meantime. And I will get the link up. You can pre-order the drug door guide, and I should have that done by next week. I'm almost done. I'm halfway there with it. I'm working on it between the baby, Okay. All right, guys. Thank you guys so much. Have an awesome, awesome Sunday. I will be in your guys' inbox, I think, later, those of you that are on my email list. And have an awesome rest of your evening. All right. Bye, guys.